My name is Kishiko Ohkoshi. I am a professor of St. Lucas International University, Tokyo, Japan. I have been using MicroPulse Laser since 2003. I am the first user of MicroPulse Laser for clinical practice in Japan. The concept of MicroPulse Laser is unique technology to treat various macular diseases without damaging foveal photoreceptors. This laser enables us to treat various macular diseases which had been difficult to access with laser treatment. Since I started to treat my patients with this laser, I no longer had to be concerned about macular damage after laser treatment. I think the mechanism underlying MicroPulse laser is based on heat shock protein upregulation. Sublethal photothermal stimulation with a MicroPulse laser may facilitate heat shock protein 17 expression in the RPE without inducing cellular damage. In our in vitro experimental model, heat shock protein level is elevated after sublethal photostimulation with MicroPulse laser on a single layer of densely cultured ARP19 cells as a model of the human retinal pigment epithelium. Because heat shock protein may block the activity of apoptotic and inflammatory pathways that cause cellular damage, upregulation of heat shock protein 70 expression induced by laser irradiation is thought to be important for reducing macular edema following clinical laser therapy. Heat shock protein may be the trigger for improving the RPE function. When I started to use MicroPulse laser, I was very pleased to not find any laser-induced retinal damage. No patient complained scotoma after treatment. No laser scar was seen. Some patient told me, I can see better after laser treatment, even if visual acuity was not improved. Anti-VEGF injection for DME has shown good results recently, but repeated injection is a burden for patients socially and economically. In this anti-VEGF era, laser treatment is still an important treatment strategy for DME to prevent fovea involving DME and to reduce the number of injections. It has been reported that laser treatment reduced the number of injections in DME treatment. However, conventional modified ETDRS laser is not advocated because it induces laser damages. Therefore, in my practice, combination therapy with MicroPulse laser and anti-VEGF injection is used. There is a lot of evidence that shows subthreshold MicroPulse laser is equally effective to modified ETDRS laser with conventional continuous wave laser. Therefore, I would say if there were two treatment options to treat your patient with DME, and those methods were equally effective, but the first method induces irreversible macular damage, and the second method does not, which method would you choose? I have experienced a lot of attractive cases using MicroPulse laser. In my practice, a gentleman with DME who was non-responsible to multiple anti-VEGF injections was referred to me to treat with MicroPulse laser. I treated him with 577 MicroPulse laser, and macular edema was reduced with a single session. That was the most attractive case for me. In my practice, non-damaging MicroPulse laser has now completely replaced conventional continuous laser treatment for most of macular disease, such as DME, RVO, CSR, and etc. For DME and RVO, MicroPulse laser is used either monotherapy or adjunct to anti-VEGF therapy. When macular edema is advanced, I would treat with anti-VEGF first, then apply laser. In CSR, I have been able to intervene earlier since I started to use MicroPulse laser. Various laser technologies which provide tissue selective application are now developing. In the future, we may achieve the technology to create photostimulation or thermal damage to the specific layer or location of retinal tissue based on the surgeon's need. In 3 words, I would describe MicroPulse as sublethal photothermal stimulation.